Okay, well, welcome everybody. We're so glad that you could join us for today's Illinois Prescription Monitoring Program Lunch and Learn. I can't guarantee the lunch, but I can guarantee the learn. I'm really excited to have as our special guest today, Dr. Laura Meyer-Junco, who is on faculty with UIC with their School of Pharmacy. Additionally, she is the editor-in-chief of the Journal of Pain and Palliative Care Pharmacotherapy. And the reason that I thought it would be really interesting to have Dr. Junco with us today is that she has really come up with some interesting ways to educate our patients regarding pain self-management. And so I was hoping that she could share with us today some of the tips and tricks around self-management, non-pharm modalities, et cetera. So if I could I ask you, Laura, to introduce yourself and tell us a little bit about how you got started in all of this?
Okay, well, I think you did a great job. So I'm introducing me. I'm Laura Meyer-Junco. I'm a clinical assistant professor at the University of Illinois at Chicago, College of Pharmacy on the Rockford campus. So I've been there since 2012. I teach in the pain and geriatric curriculum. Also the editor of the journal, as Chris mentioned. So my journey to pain self-management was kind of a winding path. But before I talk about that, I think I should define for you what pain self-management is. So basically, it's a person-centered approach to pain. So it puts the patient in the driver's seat. They're the active driver of their pain care, and it allows them to shift from a more passive role to an active role to really, engage many aspects of the biopsychosocial approach to pain to allow them to live a healthy life with pain. So basically, at its core, the patient has to understand the pain condition and a little bit about how pain processing works, particularly the involvement of the brain and the nervous system. And then it gives them skills for dealing with the everyday consequences of living with pain. So this is, how do they manage their thoughts and behaviors? And why is that important? Because these negative thoughts and behaviors impact the pain experience. And so it gives them strategies for what they can do about pain and how to take an active role. So there's many components to it. Pain self-management programs are very comprehensive because they take many non-pharm modalities and put it together in one program. So you're getting cognitive behavioral techniques, you're getting pain education, particularly pain neuroscience education. So the role of the brain and the nervous system in pain. You're getting some introduction to the importance of exercise, as well as a gentle exercise program, and a lot more. It's designed for patients with all types of chronic pain, because regardless of the pain etiology, all patients with chronic pain suffer from the consequences of living with pain. So there's a lot of similarities among patients when they participate in this program, regardless of whether their diagnosis is musculoskeletal, fibromyalgia, functional GI disorders, etc. So it's very exciting, and I really want to create awareness about what pain self-management is. So I'm very grateful to Chris for having me here today to increase some of that awareness. So how I stumbled upon pain self-management myself is that I was doing co-visits with a physician in a cancer center clinic for palliative care patients. And I felt that we did a great job managing the physical components of total pain, but really weren't doing so well with managing the other components of the total pain experience. So emotional pain, psychological pain, existential pain. And at the same time, I was in a geriatric assessment clinic. And for those patients with pain, they experienced a lot of frustration because providers were hesitant to prescribe, NSAIDs because of comorbidities, hesitant to prescribe opioids because of a variety of reasons, including risk of falls and cognitive impairment. So it left the patient very frustrated. And for myself, I was frustrated. How can I help these patients, particularly when certain medications are off the table? So I started looking into cognitive behavioral therapy for the practitioner. So I pulled a book from Beverly Thorne. It's called Cognitive Therapy for Chronic Pain, a step-by-step guide. And that was very helpful. But then I found that I wanted to see what textbooks were out there for patients on cognitive behavioral therapy and some of these behavioral therapies for pain. And I wanted to borrow the patient language so that I could use it myself. So with that, I found this textbook. I don't know if you can see it, Living a Healthy Life with Chronic Pain by Dr. Sandra Lafort. And this is directed for patients, but still a helpful resource for practitioners. And within this textbook, I learned about pain self-management programs that were developed at Stanford University that are highly evidence-based and have been studied in clinical trials. They reduce pain, they reduce dependency on others, they improve self-efficacy, etc. So a lot of benefits. So then I stumbled upon the Stanford's Pain Self-Management Resource Center online and tried to find one of these community-based programs that's based on this textbook in my area. I'm in Rockford, Illinois. There really isn't access to pain psychologists. There turns out to be not pain self-management programs through Stanford available either in this area. So I found a program in Wisconsin actually and drove 1.5 hours for 6 weeks, 1 day a week to participate in a pain self-management program. And I found that it just had an enormous impact on the patients in the group. And it had a support group feel with also this educational feel, and they were really learning some real skills. So I decided I wanted to do this. And so I realized it was a little bit more cumbersome for me to just start this. Because it's an evidence-based program, I had to undergo training to be able to deliver the program. And so finally, after COVID was a little bit of a setback, I got it established in my community. So since 2021, I've been running some, I've done 4 or 5 now at this point. There's 6-week pain self-management workshops based on the Stanford model. And it's been a fabulous experience. The biggest part is getting the word out. But most patients, when they do come to the workshop, express a lot of frustration, about their pain care. And also many express that they have never heard of pain self-management and they were glad that they stumbled upon it. So that's kind of my journey into pain self-management. I think there's still a lot that needs to be done to engage patients in this, to engage providers in this, to engage policymakers in this, so we can have greater access to these pain self-management programs, because they're not everywhere. And awareness is about the programs in general is pretty poor. So hopefully this will increase some awareness about the programs, and including my program. It is a free workshop. If you have any interest in getting your patients enrolled in this program, I created a separate email, so my UIC email does not get bogged down, but it's alifewithpain@gmail.com. It's free. I try to offer it twice a year if I can, usually when I don't have students. So if you have any patients that are interested in this, or you're interested in learning more, just send an email to that Gmail address, and I'll try to get you connected or get your patients set up with my next workshop, whenever that might be.
Laura, is this a virtual workshop or is it live in Rockford?
It is virtual. So I think that was a good thing that came out of COVID, is it went from an in-person experience, which makes it a very much regional experience or local experience, to online. So currently in the workshop that I have going now, people are from Wisconsin, northern Wisconsin, Illinois, all over Illinois. We have somebody in Ohio. So the virtual platform makes it much more accessible. So, and also for patients in pain, they don't have to travel anywhere. So from the comfort of their living room, we all engage in the workshop together. So thank you for pointing that out. I didn't mention that it is virtual.
Oh, no. So I feel bad for monopolizing the questions. And for those of you who are with us today, if you do have any questions for Dr. Meyer-Junco, please throw them in the chat, and if she doesn't see them, I'll make sure to point them out. You had mentioned earlier when you were doing that very nice introduction into pain self-management, you used the term biopsychosocial model of pain. And I know that we use that term quite a bit. For people who may be joining us today who don't spend every day of their clinical life in working with patients with pain. Could you dive into that a little bit and explain what that really means?
Okay, so the biopsychosocial approach to pain means that we have to understand that pain is a multi-dimensional experience, that we need to go think about pain by going beyond just the physical dimension, that pain, chronic pain, is a complex experience with interactions between the patient's physiology, their psychology, emotional, social factors, and even spiritual and existential factors. All of these feed off of each other, and there's a complex interplay that creates the phenomenon that is chronic pain. And if you even look at some of the neurobiology and like functional MRIs, there is a basis for this in molecular neurobiology science. When a noxious stimuli enters the brain, it interacts with multiple components of the brain, including the limbic system, including the prefrontal cortex. And it's thought that when patients have, an increased, or a negative emotional state, that there is increased activity in the limbic area of the brain, and that worsens the pain experience. So I think it's very important that we recognize that pain goes beyond the physical dimension, and that patients, psychosocial factors can really influence and worsen, and maybe even sometimes be the reason why their pain is persistent. And so I think, especially for more centralized pain syndromes like fibromyalgia, we really need to be thinking about the other components of pain, so the psychosocial components, and not just the patient's biology. So hopefully that kind of explained it, that there's a lot of factors going on, and that's why, when we talk about, multimodal therapy for pain should also include non-pharmacological therapies that address the psychosocial components. And to understand and direct which non-pharmacological therapies patients would do well with, we have to learn about our patients as individuals. What are their beliefs about their pain? Do they have fear about their pain? How do they view themselves because of their pain? And trying to work with that so they can get their lives back. So it's a lot, and I think sometimes that's difficult to accomplish in terms of engaging with all these parts of the model in a 15-minute visit, but kind of doing it maybe stepwise, or looking for these community-based programs like pain self-management programs could really help patients understand this approach and dig into aspects of their lives that are contributing to their pain experience.
Okay, thank you. So I'm curious, if you had a captive audience of, let's say, primary care providers, what would be maybe the top 2 or 3 things you would want to teach them or make sure they knew before you release them into the world?
So I would like them probably to know that pain education in of itself can be an important treatment. And so, in the rush of an office visit, we should take some time to provide some education surrounding pain. And this education could be about the biopsychosocial model of pain, so that patients start to have an understanding that their cognitions and their behaviors do contribute to their pain experience. And it can be difficult to get buy-in from patients when we talk about psychosocial approaches, because they don't want to think that pain is all in their heads, and it isn't. I think a nice quote is that the mind matters in pain, but it's not mind over, it's not mind over matter in pain, but the mind matters in pain. And so I think that's important. And incorporating, I think, some kind of analogies and metaphors, borrowing from the concept of pain neuroscience education, can be helpful to explain to patients the biopsychosocial approach in a very short amount of time. So one analogy that I like to use that's kind of pain neuroscience-esque is about the brain's neural matrix. So I tell patients that, one, we want to reframe for patients that pain is damaged to that pain is a perception. And the brain is the command center of our nervous system. And it relies on essentially 3 pieces of information. So this is very simplistic, of course, to decide if the body is in danger. And if the brain decides that the body is threatened and we're in danger, it's going to ramp up the amount of pain that we feel. So these three pieces of information that the brain relies on, obviously are our body sensations. So that incorporates the physiology, so the bio part of biopsychosocial. But the brain also relies on information that it's already stored within the brain. So this can be our thoughts and our emotions. So if the patient is catastrophizing or making worst case predictions about their pain, or they're fearful of their pain, that information could cause the brain to sound the danger alarm and ramp up the physical sensations that they feel, ramp up the amount of pain that they feel. So sometimes I tell patients, well, we have medications, but medications are just one part of addressing pain, because the medications may help maybe with that body sensation part of the biopsychosocial model. But in well-controlled trials, analgesics maybe at most reduce pain by 30 to 50%. So what else are we going to do? And the other things that we need to do is to address the two other pieces of information that the brain relies on. So our thoughts and our emotions. And so one thing that I, engage patients to do is to think about what's important to them, what they value in life, and that then becomes like a functional goal. What would they like to achieve, and try to work towards that, and putting more opportunities for enjoyment and pleasure in their life to improve those thoughts and emotions, because that in itself is a modality for reducing the intensity of pain. So sometimes using simple kind of constructs like that can help, change a patient's, or help move them towards changing their relationship with pain, that there's more than just the physical dimension, which they may not have much control over, but there is the psychosocial dimension, those thoughts and emotions, which they do have control over.
Laura, do you find that it takes multiple interactions with a patient before they are ready and willing to fully embrace the self-management process, or is it usually pretty immediate once you bring it up?
So I think when I try to bring up the self-management concepts and the brain neural matrix with clinic patients, it takes a little bit more time. First, I might not do it on the first visit. I might want them to get comfortable with me and recognize that, yes, we're still going to use medications, etc. And then maybe on subsequent visits, bring in the other pieces to try to build that level of trust. With the workshop, what tends to happen is you tend to get more motivated people in general. And so there's a little bit more buy-in from the folks in the workshop. Many of them have already kind of dabbled in some things like mindfulness and are aware of the mind-body connection. And so for those folks, sometimes it's a little bit more immediate. I mean, you'll get some people that are like, well, no, this workshop is not for me. This seems like, psychobabble or something. So the workshop probably has a little bit of a selection bias in terms of who participates and who completes it. With clinic, you get, everybody that is, coming from different walks of life and different exposures to pain treatments. So that becomes a little bit more challenging. And so you have to tread lightly and cautiously so you don't lose them in this concept.
I mean, I've heard of some like big family medicine practices, not here in Illinois, but in other areas where, if a patient is going to undergo opioid therapy for chronic pain, that it's mandated that they participate in programs or educational sessions like this. And so that I'm curious what your thoughts are around, is that create a situation where it's not gonna fit or to kick in the way that you'd like it to?
Yeah, I mean, I feel like if it becomes more of a forced engagement instead of voluntary, it may maybe leave a bad taste in the patient's mouth. But I think with these pain self-management workshops, they get to see and engage with other people dealing with similar consequences of pain. And I think depending on how it's delivered and the amount of empathy from the facilitators of these pain self-management programs, that makes a big deal in terms of, how responsive patients are to it. But I think it's very important. There is pieces of the pain self-management workshop that do address medications. It's definitely not the emphasis, but it kind of expands patients to the idea that medications are just one piece, the opioids are just one piece, and then we have other things in our toolkit to try to manage pain and the consequences of pain. I think studies are coming out, more research is looking into whether pain self-management programs are opioid sparing. I think at this point that we're not there, but I think there might be some literature. I think I see Beth Darnell doing something to try to see if using pain self-management strategies, if that can be an opioid sparing modality. I mean, it probably does reduce chemical coping, right? Using the opioid for chemical coping because it provides them other tools for coping. So I actually think that's a great idea. If someone that's prescribed an opioid also then is enrolled in a pain self-management program, hopefully they're open to it. It may take some work on the part of the facilitator to increase that openness. But I think that's awesome, actually. I think that would be great if there's the availability of such programs.
This is fascinating. When you do your workshop, you said it's a 6-week program, correct? Is it designed such that patients can kind of hop in and out, or do they really need to be there for every session in order to get any benefit from it?
So the Stanford model is a 6-week session. That is in 2.5 hours at a time. And I feel there is content that is learned every session that is valuable, but it could be a lot for patients to engage in that length of time. I do feel, though, that even if they don't attend all the sessions, and that's actually kind of pretty common, there'll be maybe just a handful that'll attend all 6. But if they intend, I feel that I'm still crunching the numbers, actually collected some data, that they attend at least 3. One of them is at least the very first one, because that's where we get the pain neuroscience, that they still derive benefit. I had a winter program that I did over the holidays, because that's when I had free time to do it without students. I realized that was not a good time for participants. So we actually had to cancel it halfway through because there was a lot of absences. And one gentleman emailed me and he said, and this might have just been tongue in cheek, but he said, well, we got most of what we needed from the first couple sessions and many of us feel better. So we're just, doing the holiday thing now. So I kind of want at some point to maybe branch off from this program and develop my own program that is shorter. So maybe 3 weeks long or something, because it is, because right now we just did the 5th one and we have the 6th one next week. Usually right in the middle around week 4 is probably the lowest attended one. It's just like there's a little slump there and then they come back for, the following workshop. But, we had patients getting hip surgeries, having MS flares. There's things going on in their lives where they just can't be there. So it's definitely understandable. But yeah, that's an issue with the length. But I don't think they need to attend all 6 sessions to get the full benefit. And I'm going to kind of crunch those numbers to see if that's actually true, if my hypothesis is true.
How many patients typically, or clients, people, I don't know what we should call them in a scenario like this, but how many typically do you have in a cohort?
So the idea is to keep it small. So for a virtual workshop, I'm supposed to only enroll a maximum of 18. So you enroll 18 and then probably on day 1, less than that will show up. So the idea is actually to keep it no bigger than 10 to 15. So it makes it more difficult to reach a lot of participants, especially if I only offer it twice a year. But I do feel that if it is smaller like that, there's a lot of sharing and brainstorming and problem solving together to make them active managers of their pain, that the smaller group dynamic does make participants more willing to engage. So that's why I think there needs to be more of these programs, because you can't get a lot of people enrolled, but you need a smaller cohort to really reap the benefit, I think.
Sounds like a potential grant opportunity.
Yes, I agree.
So it looks like we have a question in the chat for you. Are you able to access that?
Let's see. Okay, have you noticed a time frame duration that a patient may be more receptive to pain self-management and accepting that you aren't just going to take away medications? Do you think the goal of reducing opioid use might be a limiting factor for patient buy-in? So that's a really good point. I have seen, examples of practitioners using pain neuroscience education to try to facilitate reduction in the opioid use. And I think, to get buy-in from the patients, you may not want to approach it like that we're going to do pain self-management, we're going to do pain neuroscience education. And because we're doing this, we're going to pull off the opioid therapy. I think by doing the education with pain neuroscience and pain self-management, it then becomes the patient's decision that, I don't think I need so much reliance on my medications, because it kind of goes into the philosophy that they are the ones directing their care. They're the active managers, and they come to the conclusion. So in some of my survey data that I'm collecting, I am looking at medication use prior to the workshop, and if they had decreased medication use after the workshop. Within the workshop, I'm not talking about, opioid tapering or getting off medications. We talk about them as a tool to use, but we have other things in our disposal that we can use. So it kind of becomes the patient's decision to kind of reduce that opioid use or reduce medication use, or try to make them feel like it's their decision if there's some sort of motivational interviewing there. So yeah, so it's tricky. That may be your end goal, to try to be able to reduce medication use, but I guess somehow you have to ensure that it's also their end goal and that they came to that conclusion maybe on their own. And that would probably follow the philosophy of pain self-management and improve buy-in, but probably easier said than done. So hopefully I answered that question in maybe a very circumventual way.
Thank you. If we could shift gears just a little bit, I'm hoping to spend just a few minutes talking about non-pharm kind of healthcare provider directed treatment modalities. And I'm wondering if you have any that you're especially interested in discussing today, or know of anything that's coming down the pipe that could be super exciting.
Okay. In terms of non-pharmacological, I do feel that where I'm most passionate is the behavioral therapies and the educational therapies. Maybe because as a pharmacist, that's more in my wheelhouse, is education and lifestyle education. I like to learn from patients in terms of what they're using for non-pharmacological therapies. Like if they found, knee bracing helpful, then I want to know about that. But kind of in general, when you're looking at the clinical trials or, systematic reviews for non-pharmacological, particularly some of the physical modalities like TENS units or bracing or massage, very inconclusive evidence, but generally kind of lower quality evidence. So I kind of gravitate to what I can do and what's in my wheelhouse, which is pain self-management. But I do feel like it does have the support of guidelines. If you're looking at any contemporary national and international guidelines on musculoskeletal pain, you're seeing that there is recommendations for use of pain efficacy, sometimes they call it, or self-efficacy programs, educational programs. So there's a lot of support behind that. And also the National Pain Strategy is emphasizing the importance of pain self-management. So that's kind of, it's not new. It's been around, but I think it's gaining more traction. Another thing that is maybe not your traditional non-pharm thing, if you're thinking about acupuncture and such, is pain neuroscience education. And I feel like this is becoming more mainstream. I'm seeing a lot of online resources for patients that you can direct your patients to. So one that I really like is retrainpain.org. So basically it's a bunch of pictures that explain the role of the brain and the nervous system. It basically explains neuroplastic changes that happen in the nervous system and how they can do strategies to calm the nervous system. But it creates an awareness to this picture-based clicking. And I would encourage you as a clinician just to look at it because it gives you the patient language. But there's also other tools like paintoolkit.org, which is online pain self-management resources. Patients are always telling me about apps that they're using, where they're using mindfulness apps or, somatic tracking, all of these various devices that are out there. So I would really encourage folks to explore some of these behavioral therapies. I think the guidelines, are recommending those, and there's no real harm. There's no harm, there's no toxicity from them, except maybe time toxicity for trying to find the program, and maybe some financial toxicity. But the community-based programs are generally free or just the cost of the textbook, which is usually $25. So
And
I don't know if that answered your question or was very biased towards.
No. And that actually, that kind of brings us to the last question that I actually had was, you had mentioned a bunch of resources just now. If somebody was really interested in diving deeper into this to help their patients out, is the textbook that you held up earlier the gold standard you'd really like to?
Yeah, I would encourage this one because it is directed for patients. So I think it's still helpful for clinicians because then you get the language that you can use with clinicians. So I would start here if you're just interested in what pain self-management is, what it involves, very basic pain neuroscience information. And then if you're looking for more, this is also a book that can be used with patients or for patients, but it's Explain Pain. And so this is an illustrated guide to pain, gets really involved in terms of what's happening in the nervous system and how, our behaviors, lifestyles, thoughts can influence that. This is very dense, I feel, but from here, I have borrowed analogies that help me explain things like this danger alarm in the brain, things like that. So there's a lot of usefulness there. Another book I have is by Adrian Lau. So he's a physical therapist that is really involved in pain neuroscience education. It's an older textbook. It's called Therapeutic Neuroscience Education. But I like this one as well because it covers the history of what pain neuroscience education is, the clinical studies, and then it goes into the analogies to use with patients and why to use them, what pictures to show them. So it's pretty fabulous. So I think it's a great resource. You might want to pick and choose what's in it. Some of the analogies I think are maybe too much for the short amount of time you have with patients, but there's probably something in there that you can use and probably more than one something. So those are some of the books that I think are very helpful. And there's lots of things online too that you can use.
Do you feel that there's any overlap between pain self-management education and neuroscience education and trauma-informed care?
Yes, I think there's a lot of overlap, and it took me a while to understand the different nuances in terminology. Like I kind of stumbled upon pain neuroscience through doing pain self-management. And then I'm like, wait, what we're doing in terms of the pain self-management program in the first session, we're talking about the brain pain connection and the nervous system being oversensitive and how patients can influence that. And then I realized that discussion actually could fall under the umbrella of a fancier terminology, pain neuroscience education. And then trauma-informed care, kind of, I think, is through, weave through all of these things because the neuroscience textbook will talk about, if an injury occurs in somebody that had, a stressful event at the time or a childhood trauma, how that escalates the pain experience for that individual and kind of the basis for why that might be. So there's a lot of overlap. And I think sometimes wading through the different nuances and terminology can get a little confusing. But but it's good to have all of these resources out there that are coming out that we can use.
Okay. Have you already filled up your next workshop cohort?
No, I have not. So I haven't decided when I'm going to offer it next. It's probably going to be in spring 2024. So if you have somebody that in mind that it would be a good candidate for the program, I'll just have them email me. You would have the patients email me. And then what I do is when I have my next workshop coming up, I'll just send an email to the folks that are on my list, basically, because I collect emails. So I probably should have a set workshop schedule, but I don't, because it's all kind of based on what's happening with me at UIC at the time. But I'll type in my chat what the email is. I can also send you a flyer. So if you're interested in, learning more about the program or just want to have it on hand to provide your patients, it's a lifewithpain@gmail.com. Completely free. The patients just have to pay for their own textbook until I get another grant to cover the textbook.
How much is the book?
The book is about depending on where you get it, Amazon or from the publisher, between $20 and $25.
Okay.
So pretty reasonably priced.
Okay. And I guess this next question is for Eric Huff or one of the other representatives from the PMP that are on today. Is it potentially a possibility that we could take some of these resources, these pain self-management resources, and find a way to link to those on the PMP website for providers who may be wanting to steer some of their patients towards these really valuable modalities?
We are always looking for valuable resources to share on the website. And Laura, if you are interested in sharing a flyer to advertise the program or any information, we share a monthly newsletter. We're always looking for additional information to spread the word. We all want the same thing: improving patient care, being beneficial. And the PMP, we just want to be just another tool in the toolbox as a resource. So yeah, absolutely, we can work on adding any of those resources. I started trying to pull up websites that you mentioned, Laura, and if you don't mind, either type them in chat or let Chris know any websites that you would use as a resource. We can link those as well.
Okay, let me type some in here. I hope I'm spelling it right. I could send you, actually, maybe I have kind of a compiled list for myself that I like to look at. I'm also interested in, there's like CBTI, or cognitive behavioral therapy for insomnia program offered through the VA. Managing sleep is so important to managing pain, and that's another online resource. So I've been trying to collect these things for myself. So I can, Chris, I can send you a list of some of these online resources I've been collecting, either through my stumbling upon it myself or people in the workshop tell me about it. And then also, Eric, it'd be great if we could put a flyer on the Illinois PDMP for the workshop, the pain self-management workshop. That'd be awesome. Oh, there's your email. Perfect. I'm gonna write that down. Thank you.
Well, for those of you who maybe didn't have time to go grab a delicious sandwich before you logged in, I think that will give you some of your lunchtime back to hopefully go get something tasty. I can't thank you enough, Laura, for joining us today. Thank you to the Illinois Prescription Monitoring Program for sponsoring these sessions. This will be the last Lunch and Learn of this year, but please stay tuned. We hope to continue to do these into the future. And again, remember, a full recording of this will be on the Illinois PMP YouTube channel, and I believe that's also linked on the website as well. So again, thanks to the folks at the PMP, and thank you, Dr. Meyer-Junco. Always good seeing you. Hopefully I'll see you at Pain Week in a couple of weeks, and
I'll be there.
We'll keep doing all the great learning.
Sounds good. Thank you. Thank you for having me.
Everybody. Stay cool out there.